Our next speaker is Sarah Swarthout. So Sarah is a nurse practitioner who spent some nursing time in emergency care, critical care, and so has a lot of experience with that before joining us as a neurology consultant, basically on our inpatient consult service at the main campus. And has taken on a variety of roles in terms of not only seeing patients, but interaction with other residents and orienting people, and has really developed a really unique role. And so we wanted her to come and speak just on her experience and her role and how she's developed it, to hopefully give some insight maybe to others and how they're trying to incorporate APPs into their practice. And so without further ado, please welcome Sarah.
Thank you, Dr. Marquardt. Hi, everyone. Thank you for having me. This is my first time at the Neuro Update, and so far it's been a great experience. I'm Sarah Swarthout. I am an adult acute care nurse practitioner. I do work on the inpatient neurology consult team at main campus. In order to address the high demand for neurology needs, the Neurological Institute at the Cleveland Clinic has been increasingly utilizing advanced practice providers in both the inpatient and the outpatient role. And when I started in this position in 2020, it was a brand new role. So this was a team that had been operating without an advanced practice provider. And it was a big transition, not only for myself, but for the multidisciplinary team that I was working on, or do work on. So through this talk, I'd like to kind of share a little bit about our experience and ultimately talk about some things that have helped make it successful. So objectives here, just going to use the audience response questions to define some terms, talk about the advanced practice provider role, talk about how my role looks, how we utilize advanced practice providers on the consult services, and then talk about some barriers or challenges and keys to success. Just so I can get a sense of the room, how many people here are physicians? Lots. And how many are non-physician providers? Great, okay. And of the physicians, how many are working with an advanced practice provider or have? Wow, lots of people. That's great. Okay, excellent. So just a softball question here. The term advanced practice provider most commonly refers to A, nurse practitioners, B, physician assistants, C, advanced practice registered nurses and physician assistants, or D, advanced practice registered nurses. Okay. Looks like I'm getting a lot of responses that are correct. Okay, great. So nearly everyone got this right. The term most commonly refers to advanced practice registered nurses and physician assistants. It's important to note in the umbrella term advanced practice registered nurses, that does encompass nurse midwives, nurse anesthetists, certified nurse specialists, and what am I missing here? Yeah, no, I think I got it all. So just keeping that in mind. For the purposes of this talk, when I refer to APPs or advanced practice providers, I'm referring to nurse practitioners and physician assistants, just because that's who we're utilizing on our neurology consult services. So which of the following is true? A, for nurse practitioners, practice authority is the same in every state. Both nurse practitioners and physician assistants can diagnose and manage, as well as prescribe medication. And then physician assistants obtain graduate level education, NPs do not, or physician assistant training and certification focuses on a specific population. And again, everyone's pretty well versed in this. So that's correct. The correct answer is B. Both can diagnose and manage illness as well as prescribe medication. I think it's important to note just that for nurse practitioners, and this is also true for physician assistants, practice authority does vary by state. So if you're thinking about adding an APP to your team, it's important to understand what your state laws are and what their scope of practice is, where they're going to be working. There could be like a whole conference about scope of practice, so we're not going to go through that, but just being aware that there is a difference state to state. Both do obtain graduate level education, although that education does look a little different. PAs practice or are trained in the medical model. They can cover care across the lifespan. And nurse practitioners are trained in advanced nursing practice. And we obtain licensure, but we also obtain a specialty certification. So that's another important thing to keep in mind when adding an APP. If it's an NP, making sure that their specialty certification is appropriate for the practice setting and appropriate for your patient population. All right, so just going to talk a little bit about utilizing APPs on an inpatient neurology consult service. Here, I'm going to kind of compare and contrast main campus to our regional hospitals. It's important to highlight that we do have APPs working at our regional sites as well. And we also have APPs who are working in teleneurology. So we do have hospitals that don't have primary neurology services as consultants, and they are providing teleneurology services there. So I think this is important because it's showing that APPs are versatile. They can work in a variety of practice settings, even though the structure and flow of these teams is very different. So just comparing the two inpatient services, at main campus, we have a pretty big team. We have a staff neurologist. We have a senior neurology resident on the team. They're a PGY 3 or 4. They're not taking consults. It's their opportunity to sort of act as staff and learn how to lead a service. Myself, the APP, we also have neurology residents, PGY 1s, PGY 2s, and also non-neurology residents rotating through. And we often have medical students who are also on our service. By contrast, the regional hospitals, the team members is always a staff neurologist and always an APP. They may or may not have neurology residents on, and they may or may not have medical students. So it's a lot like tighter of a team. At main campus, we are a 24/7 service. So we are seeing consults overnight. They're seen by a neurology resident overnight who's putting in like a note and a preliminary plan of care. And then they're being formally staffed the next day, either staffed in rounds or I'll go see the patient and sign that note. At the regional campuses, they don't have like off-hour consults. So consults that are coming in after a certain time are staffed the next day, and they don't have the luxury of having like that note or initial plan that's already being put into place on these patients. I'm on service Monday through Friday during daytime hours. We do have neurology residents who are working overnights and weekends, and then the staff who's rotating through does come in on the weekends too. At the regional hospitals, the APPs are on service 7 days a week, so they're working a hospitalist schedule, typically 7 on, 7 off. And then the APPs in teleneurology are available during daytime hours. So, you know, just kind of looking at this, maybe seeing which area applies more to your practice. So we do have some unique challenges on our service. First and foremost, it's a teaching service. So we have different types of learners at different levels, and they're at different stages of learning. So they need different levels of oversight and guidance from our staff and from our senior neurology resident. And obviously, as we all know, the neurologic history exam and formulation can take a long time, especially for new learners. So we do want to allow people that time. Our volume on the service is variable, but it can be significant. I will say overall, I think that our volume has been steadily increasing since I started in 2020. Gone are our low volume days. It's usually pretty moderate and sometimes very high volume. So that can kind of dig into the time that's spent with, or the time that we have for teaching. Being main campus, we do tend to have a fairly high volume of complex cases. So we're seeing a lot of patients who are coming to us from other centers where they've already undergone extensive workup and there's still a question, or the patients coming to us for like their second, third, or fourth consult from a neurologist. And obviously these cases tend to take a lot of time. There's a lot of chart review. There's a lot of digging through previous workups to sort of understand what's going on and what we need to do. So we also need to allow time for those cases. There is a lack of continuity on the team, so staff, residents, and medical students all change on a weekly basis. And this can be challenging, especially since we have a lot of these complex cases who are often being carried through multiple weeks. So that's another challenge that we have. So how does the advanced practice provider help with all of this? A big thing is with continuity. So I'm the only constant on the service. I'm there Monday through Friday. And this allows for continuity within the service, but also continuity within the hospital. So through, working there over the years, I've built relationships with other primary teams, other consultant services. They know when I'm there, and they know that I'm someone that they can reach out to if they have a question for our team. There's also, it helps with continuity with patient care from week to week. This is especially true for like patients that we're adding to our list later in the week, like on Thursday or Friday. Their workups often carrying over into the next week when we have a brand new team, a brand new staff, brand new residents. So I can, I sit in table rounds in the mornings, informal rounds. I hear about all the patients just as everyone else does, so I have a good understanding of the list, and I can usually provide some insight into like the more nuanced parts of their care that maybe is getting lost in translation in the notes. I also help with burden reduction. That's probably the number one reason that I was hired. So over time, as I've become more proficient in my role, I can see bread and butter type consults pretty efficiently. So I can see these consults, knock it out for the team, and they have more time with, these teaching type cases, these zebras as we like to call them, and complex cases for the residents. Staff does not see my consults physically unless we decide that that's necessary. So that is a huge time saver. It takes a lot of burden off the staff. They don't have to like go back and rehash and examine history. We discuss the case, and then I write the note and I sign the note and bill for it. So there's a lot of time, that freed up from that. And as I said, more teaching time for complex cases. And then overall, there's just less burden for the senior resident and staff in regards to me because I understand the logistics of the team. I know how to put in orders, call other teams, page, like all these questions that maybe newer residents have or medical students have. They don't have to worry about that with me. I'm just kind of operating in the background. There's also a leadership component to this role. I do help to assist staff and other team members with logistics. Since I am on the service so often, I can answer more logistical questions. How do we deal with this particular situation? Is this an appropriate consult for our team? These kind of things. Because especially like in July, even our senior residents are new to this role, so they have a lot of questions. And then our staff, I think we have over 20, maybe 25 staff who rotate through the service. So sometimes they're only on a few weeks a year, so they may have questions as well. I help with the guidance of medical students and non-neurology residents, helping them with those logistical things so that there's not 100 questions going to the senior resident every day. And then I do help with medical student education. There are some barriers for, and challenges for nurse practitioners entering into the field of neurology. I think first and foremost, the big thing is the lack of formal education in neurology that we get. So most PA and NP schools really are lacking in clinical neurology training, and that's just the reality of it. Like, it can't be denied. So, there are some schools that offer maybe a elective in neurology where you can do a few weeks of extra clinical neurology time. There are some hospitals that do offer a postgraduate like neurology fellowship for APPs, but we're still at the point that that's kind of few and far between, so it's just not the norm at all. So we're really lacking in that clinical neurology training and localization of complex neuroanatomy. And as a result, it's a very intimidating field to go into for APPs, so I think we tend to kind of shy away from it. And it's also really hard to earn the respect of your neurologist colleagues because their training is completely different than ours. and as a result of that, training in itself can be very challenging. So, it can be very costly and time consuming because we do require a lot of training up front just because we're not coming into that from our education. And then there's always a fear of retention. So is the APP going to get into this and say, I didn't really understand what neurology was all about because I wasn't exposed to it that much, or feel like they're in over their head or they're not supported. So I think that's a big fear, like, is it worth it to bring someone on who may not understand? But I do think it's, obviously it's possible, and I think APPs can be successful. I think that one of the most important things is that overall there needs to be buy-in from leadership, staff neurologist, residents, anyone else who is going to be working with the APP. They need to believe that this is going to be a valuable team member. So that is like the first step, I think, to bringing someone on board. Mentorship is also huge. I kind of feel like I was carried like a baby by our staff and our neurology residents when I first started. And I think that's the reality of it, is that there's a lot of effort that needs to be put in up front to get the APP, off the ground if they don't have prior neurology experience. But it sort of needs to be looked at as a long-term investment. So, it can be time consuming. There's a lot of work that needs to be done by other team members to kind of help support this person in the beginning, but ultimately it ends up paying dividends in the end once they're working more autonomously and they're kind of taking that burden off the service ultimately. So for me, and I know the other APPs who work at the regional hospitals, that was in the form of working closely with the staff neurologist. So when I first started, I operated much like a resident. I would get assigned a consult, see the consult, do a history exam by myself, make a formulation, and then I would present it formally just as a resident does, get direct feedback, and then the staff would go with me to the bedside and watch me do the exam, talk to me about what they agreed and disagreed with. And it was really the hands-on learning that kind of got me to the point that I'm at today. So that's huge. I also work really closely with the neurology residents, and they have always been hugely supportive of the role. I think it's important, obviously, to have a motivated learner. So you need to find an advanced practice provider who's excited about neurology and willing to learn about it. There is obviously an onus on the new APP to read and be current. You obviously can't rely on staff to be teaching you everything. So they need to understand how to look up research and find high quality information about the cases that they're seeing. And then I think role definition is also super important. So ultimately, APPs should be practicing at the top of their scope of practice to the fullest extent of their education and training. And, in this role, that meant that I wasn't working incredibly autonomously at first because I still needed training. But as time went on, I become more and more autonomous. And then I still rely on the neurologist that I'm working with when I do have a question. So because it's always been a supportive environment, there's no egos involved, I feel completely comfortable saying, I've never seen this before, or this case is really tough, like I don't really understand what I'm looking at on this component of the exam. And the neurologists I work with have always been supportive, willing to come give feedback. So I think you need to foster that environment where people are comfortable asking questions, and they don't feel like, oh, I'm going to be looked at like I don't know, what I'm doing. But yeah, I think that's a huge part. So overall, that's kind of what I had to say about my role, and I hope that gives you some ideas about how you can use APPs in your own practice.
All right, thank you so much, Sarah. And for our last, but certainly not least, talk of the day,